All right, I'm just getting a few things ready to go, and we will get going here. Just want to make sure. Let's see. I wanted to check with everybody to see if the feed is coming through properly. If you are seeing the feed in full screen, please, if somebody could let me know, that would be fantastic. All right, is everybody seeing the feed, the video? Lori and Joe, could you just text on the thing real quick? Okay, got it. All right, great. All right, wonderful. All right, so I want to welcome everybody to our first live broadcast, and goal is to try to do these every week or every other week, and to focus on various topics for those things that each of you would like to hear and see about. So I'm going to really depend on you giving us some feedback. Today, I really want to focus on doing some implant planning. So again, if you can ask some questions along the way, that would be good. Or if there's anything in particular you'd like to see, if I could bring it up, I would do that for you as well. So let's go ahead and move over to the slide deck here. So, I think one of the questions that we always ask ourselves is, why do we get cone beam imaging? And I think cases like this are a great example of why we got cone beam imaging. Really what this shows me are implants that are misplaced, making it difficult for us as restorative dentists to restore these. And I think we're always often thinking about one of the things that drives us to use this technology is being able to place these implants ourselves on our patients to avoid these scenarios. Now, I always like to say that one of the pitfalls of guided surgery, or the limitations of guided surgery, is totally based on your plan. And what I mean by that is that, if your plan is not correct, your final result is not going to be correct. So many general dentists, and especially certainly those who are new to implant dentistry and with 3D imaging, are going to be what I call crutched by having the surgical guide. And certainly I'm that way myself, but I think what we have to realize is that our plan is unbelievably important to be able to create a great result. And to kind of give you an idea, I always like to show this slide here that kind of, and ask the question, how is this implant placed? Are we happy with this placement? And oftentimes, I'm trying to get something here. Oftentimes we look at this and we often look at it from a singular perspective. And in looking at it in a singular perspective, we're not seeing everything. So if we were to take a look at this, what we would see here is an implant that's, well placed within the bone. Okay, certainly we can see part of maybe this part of the thread is outside of the bone, which, and oftentimes if we're looking at this from a pure surgical perspective, we would have a tendency to bodily move this implant that way. And the other thing that we look at here is we can see that this implant is kind of well centered between the teeth. So, you know, we can make some minor changes to this and think that we have a good plan here. But really what I'd like to draw your attention to is that this plane is going like this. And what we do know is that in a perfect world, our occlusion should be going down the long axis of our implant. And if we look at our upper teeth here, just like so, what we can see is that it's not going to hit the implant in the long axis. In fact, it's going to be hitting the implant at an angle. And, you know, the truth is this probably won't be that big of a deal, but it's not going to be that big of a deal. But over time, this can create an issue. And really what I take issue with is that with all this technology, why would we allow ourselves to have a not perfect result? And so with a little bit of tweaking, we can get a plan that looks somewhat like this. Now again, still in this situation, our implant is just outside of the bone here on the buccal. Now that will be grafted. Okay. But what we also need to look at is that our occlusal plane is correct. We're still centered between the roots. And more importantly, when we look at this, we can see that we're going to be able to create an emergence profile that's going to minimize food trapping between the implant and the natural teeth. So we want to make sure that we have these things. So one of the things you can look at here is, again, the difference in the occlusal plane here versus here. It's literally a 1 minute, not even 1 minute. Honestly, it's a 10, 15, 20 second fix to be able to create more ideal long axis occlusion onto our implant to minimize bone loss. And then again, a much better emergence profile. So I want to welcome everybody. I believe we have Jeff has just joined. Thank you, Jeff, and Greg and David and Lori and Brad and Joe. I think my office team members, for some reason, I guess they don't get enough of me at home, at the office, so they want to come and listen to me some more in the evening times. The other thing I would like to point out here is one of the issues, or one of the things that we're moving more and more towards is being able to do screw retained restorations. So when we look, one of the things I'm looking at with this particular plan is our screw access, as you can see represented here by the yellow box coming out of the implant in the software, is going to be like this. So I can't draw very straight today. But our path of insertion is going to be these lines here. So let me see if I can make these in red. So our path of insertion is going to be kind of like that. So, you know, now we're getting the issue of, are we going to be able to seat this? Are we going to end up needing to go to a custom abutment with a cemented restoration? Whereas here, we can see that by having a more ideal placement, a restoratively driven implant placement, we can see that our path of insertion is along our implant. So there's our other benefits for it as well. So again, one of the things we also want to look at is screw retained path of insertion. So that's important to look at as well. So, you know, just again, keeping our eyes on certain aspects here. So, you know, so let's take a look at another one here. And now we'll take a look at this, and what we'll see again is we are relatively well centered here, centered like so. You know, we've got a restoration, not bad of a food trap. We can certainly see that right here the mesial is bigger than the distal. And then when we look over here in terms of amount of bone that we have, we can see that the implant is well centered. But the truth is, this is 3D, not 2D, and we have to take a look over here. And this is important because what I'm looking at here, and the way I kind of mentally visualize this is, excuse me, oh boy. The way I mentally visualize this is when I'm actually doing my planning with or without CEREC data. I will draw a line on my lingual. I will draw a bounding box on my buccal, on my contact here, my contact here, and ultimately what I'm looking for is to get my implant dead center within this rectangular box. And this is kind of what that's going to look like here. So, hey Nikki, how are you doing? Thanks for joining, and Heath as well. So we want to kind of be right in here. So in here what we can see is that our implant is planned over here. So we want to keep in mind all three dimensions. We want to look at it from the mesiodistal in terms of the right here. We want to look at in buccal lingual here in the center, and we want to look at the restorative position right here. So because after all, we are doing restorative driven implant placement. So we want to make sure that we're keeping our eyes on these facts as well. So just kind of some food for thought to give you some ideas there. And here is the plan adjusted. Again, if we go back and forth here, we can see it's hardly anything. And the other thing that you can take a look at here is that right here we can see our upper tooth is there, and our implant is actually going lingual to our upper tooth. And the other thing that can give this away is in the tangential view, you're not seeing any upper teeth right here. Now, I do want to point out that we are working in the implant aligned view, like so. So, you know, if you're working in the panorama view, some of these principles that I'm talking about won't really apply. So I just want to, oh my God, keep us apprised of that. It's hard doing all of this at one time. So here is our restoration fixed. And what this again will show us is here we have good access, a well-centered restoration, minimal food trap, plenty of running room to design, and then we are well-centered between our lingual wall, buccal wall, distal contact, and mesial contact. We are well centered there, leaving us everything we need for a good result. So, and then the key on this one is to look at the screw retained. So this one, the one here on the left, will leave a food trap and the need for a custom abutment and the need for cement. So the food trap hurts the patient. The custom abutment hurts the patient in terms of cost and us as the dentist in terms of cost. And the cement, we know that literature is showing that roughly 80% of the time we're leaving cement behind. So we want to make sure that we're getting rid of everything there. So to kind of make this a little bit easier, one of the things that I've worked on is developing a way that I'm mentally planning my cases out. And what I'm looking at here is our implant planning worksheet that I use. And most of this is mental here. And what I'm looking at here, this is the bone. This is surgically based. These are the surgical parts. And then what I'm looking at down here are the restorative parts below the orange line. So those are all things that we're looking at from a restorative perspective, and above it we're looking at a surgical perspective. So when I say mesiodistally, what I'm looking at there is our implant relatively well centered between the adjacent roots, And do we have the required 1.5 to 2 millimeters of space between adjacent roots, or 3 millimeters of space between adjacent implants? When we look at buccolingual spacing, what I'm looking at there is the implant relatively well centered in the ridge? And does it have the required 1.5 to 2 millimeters of bone surrounding the implant? And it's really important to not just take your implant and put it 2 millimeters from, or 1.5 to 2 millimeters from the buccal plate, especially if you have a significant amount of room on the lingual. You may want to consider centering that implant a bit better and then using your tilt feature. At bone level, we're going to look at here, and we're going to look at is our implant placed at ideal bone level? And ideal bone level should be determined, one, where the bone is, and then also from the perspective of where the tissue margin is going to be. So we know that we want to place our implant 3 millimeters apical to our proposed gingival margin, and if our gingival margin is going to be changing due to, you know, a short tooth or retained primary tooth or a congenitally missing tooth, or due to trauma from an extraction for immediate placement, we need to be mindful of placing that. So you know, placing our implant 3 millimeters from the proposed gingival margin, not necessarily the current gingival margin. And vital structures, on vital structures, you know, really there's a few things I look at in vital structures. So for me, vital structures are going to be, in my order of importance, it's going to be the IA nerve, the adjacent roots. Then we would look at, from my perspective, I would look at the buccal plate, and then I would